So acute deterioration on a ventilator, very simple, very commonly dealt with condition. And just to say, how do you define? It's very difficult to define acute deterioration. Various people have tried to define it, but I would summarize it as sudden worsening of a ventilated baby. Suppose baby is being ventilated with 80 tube in situ. If there is desaturation, it's difficult to define desaturation nowadays. But again, anything below 85 on a ventilated baby, I'm not very comfortable. And our normal limit is around 90%. But if a baby is suddenly desaturating below 85%, I would be alarmed. Cyanosis visible, although you don't depend on cyanosis nowadays. Bradycardia, anything less than 100. Refractory apnea. Suppose there is apnea, but baby is recovering by itself or by stimulation, that's okay. But if you are actually having a refractory apnea or prolonged apnea of 10 to 20 seconds on a ventilated baby, I would be alarmed. And any baby who has a cardiopulmonary arrest on a ventilation, it's an emergency, and you can call it an acute deterioration. Solution, the crux of it is preventing it. You should pick it up. The baby will give you some signs. You should pick it up before it happens. So it needs continuous monitoring. You should set your alarm limits and always respect that alarm limit. Suppose I set a ventilator for 26 weeks of alarm limits of 90 and 95. The moment it goes down 90, I should think why it's happening rather than waiting for the baby to completely crash. Okay. And always follow nurses monitoring chart. That's very, very important. Okay. Nurses are very, very meticulous in documenting what is happening. Okay. And if you have nurses chart very closely, you'll never miss out on a catastrophe. Okay. So again, as any other clinical condition, always look at the history. Underlying condition. Was the baby sick enough? Was there a pneumonia? Or suppose you have given surfactant to a baby, and after 2 hours, baby, after 4 hours, baby crashes. Probably you have not managed pressures appropriately, and probably you have somewhere blockade or pneumothorax. So background will give you sudden hint of what is happening. If your baby is already on antibiotics and baby looks pale and the saturation goes down, probably you're dealing with a baby who is hypotensive. Suppose you have a PICC line in situ and suddenly baby deteriorates, I would be always thinking of chylothorax or fluid leakage somewhere. Okay. So look at the baby and look at what is happening before that event happens. Okay. Always look at the vitals because that's very important. Look at the respiration, CVS, what is the sensorium status, because that will give you a hint about the etiology of the deterioration. Okay. And always blood gases help you. Suppose a blood gas 4 hours back, CO2 was 32, and now do a blood gas and CO2 is 95. Probably you're dealing with a blockage or air leaks, some collection of CO2, which is not being washed out. You're dealing with a hypoventilative state. Okay. And previous X-ray findings will help you out. Suppose there is an pneumothorax and your baby is deteriorating fast. Probably there's a new collection somewhere. Okay. Or the same collection is not being drained properly. History, examination, and blood gas and X-ray will give you a hint what is happening. Suppose in physical examination, you look for all the findings, but particularly when your baby is deteriorating or crashing, always look for audible air leak. Suppose you take your ears close to the trachea, there'll be air leak sound audible. If that's there, probably there is an air leak and around the tube, you need to change the tube. If a baby is fighting the ventilator, probably you're not properly ventilating the baby. You're under ventilating baby. So always observe your baby, look at the findings which I have told you, auscultate, and look at the ventilator monitor. So this all will tell you, and next few slides, I'll cover all these aspects. At ventilator monitor, as I have told you, you'll need to look at the graphics, air trapping, air leaks, secretions, everything will be seen in the ventilator graphics. You also should look at the axial tidal volume. Suppose you set a tidal volume of 4 ml per kg and you are delivering a 2 ml per kg tidal volume. Probably there is a blockade, probably you're not able to ventilate the baby properly. You should always have an idea of the working PIP, around what pressure your baby was being delivered, and currently what is the PIP. Okay. Percentage leak, every ventilator shows you percentage leak. Anything more than 30%, you should be alarmed. Less than 30%, probably there is a mild veritable leak which will not harm the baby. Anything beyond 40%, people don't accept unless you have a leak compensation thing in your ventilator. Okay. Flow time curve, as already I have told you, TI. If you're giving inadequate TI, probably you'll not get proper ventilation. You have to optimize looking at the flow time curve. And there's something called auto triggering. Suppose your sensitivity is very low or there are secretions in your circuit, there'll be auto triggering where the ventilation will not be appropriate, but you'll feel that baby is ventilating, inspiring very fast. Okay. Just look at ventilator monitor and you can see all this and you can take an immediate reaction. Okay. Rule of three, look at the baby, look at the ET tube, look at the ventilator. And each thing you'll have three parameters. Whether this is a worsting disease of already known condition. Suppose there is a BPD and you see there is a spasm, there is a rhonchi in the chest and baby is deteriorating. Probably you're dealing with a BPD spell. Suppose baby was stable enough completely and there is sudden CO2 hypercarbia and hypoxia and worsening of BP, probably you're dealing with air leak. If there is tachycardia with bounding pulses, probably with the precordial pulsation, you are dealing with PDA. Or see whether you're dealing with a painful condition. Suppose there is a ulcer, there is a excoriation somewhere, and baby is crying excessively, probably will not be able to ventilate properly. ET tube, whether there is obstruction partial or complete, there is a displacement of the tube, or baby is self-extubated. Just by auscultating and seeing the baby and seeing in the graphics and loops, you can see whether baby you are dealing with this condition of the ET tube. Last but most important is ventilator. Equipment failure, circuit issues, there is some disconnection to the circuit, water trap in the circuit, water is there in the circuit, or there is a hole in the circuit, some leakage. There's sometimes very rarely, but yes, sometimes you see oxygen issues also. Oxygen failure is there, is not being delivered. You might get a sick baby, okay, who is already dependent on ventilation and oxygen. So rule of three, remember these rules. Very important mnemonic to remember is DOPE SIP. What is that? D stands for displaced tube, with the tube is displaced either out or very deep in, or it's self-extubation. Obstructed tube, partial or complete. Partial also will lead to increased respiratory effort because of small airways. So probably you might have a P pneumothorax. E is equipment failure, always look it, as already I've discussed in rule of three. And SIP is related to the baby, whether there is sepsis, shock, probably a very suddenly pale looking baby, probably are dealing with IVH. And as I told you, PDA. So remember this mnemonic of DOPE SIP. Always try to rule it out immediately when we have a crashing baby. Okay. Ensure there are always two people present when you are dealing with a crashing baby. And necessary walking equipments are already there. A ventilated baby should have a ambu bag or a T-piece stationed close to the baby. You should have a suction machine which is functioning. You should have an oxygen functioning. Okay, and you should have a systematic approach. What is that approach? Disconnect patient from the ventilator immediately and use a T-piece or ambu bag, preferably a T-piece, and connect to the ET adapter. Ensure there is 100% oxygen supply in the reservoir. If you're using a ambu bag, reservoir is functioning. Start bagging or using the T-piece at the same rate which baby was breathing and the pressure which there is adequate chest movement. Just by doing this, you'll get to know whether you're dealing with a failed system with the ET or ventilator. I'll just go through that. I have few minutes. I'll just go through that. It will take 2-3 minutes. So disconnect from the ventilator and see this. I'll go through this. So suppose there is no chest movement. If you're bagging the baby and there's no chest movement with poor breath sounds and poor saturations, there are few conditions. No air entry, probably you're dealing with a blocked ET tube. If there is unequal sounds from over left and right side, probably you're dealing with pneumothorax or a collapse. If there is no chest movement and there is breath sound over stomach, you are probably a dislodged or a displaced tube. If there is rhonchi or wheezing, probably you're dealing with a bronchospasm or a BPD spell. Okay, so no chest sound with poor saturations or on bagging, probably you're dealing with these four conditions. On the contrary, so in this condition, you change the tube, transluminate, or do a bronchodilation. Okay. Suppose there is an adequate chest movement, normal breath sound, and the baby improves on bagging. What does that imply? With the same pressure, probably there was a ventilator problem or oxygen supply. Just by bagging, if you improve the saturation without much pressure and oxygen, probably there was some issue with the circuit or the ventilator. If with more pressure, that means baby requires more pressure. Either the lung condition is worsened, you need to increase the PIP and PWP, or there is a partial tube block. Okay, the partial tube block can be normally visualized in the graphic display also. On the other side, if there is no improvement on saturation, the breath sound is normal, but there is no saturation improvement, There can be tachycardia or white pulse pressure, which probably you're dealing with a PDA. If the baby is lethargic, probably you're dealing with sepsis. If there is saturation difference and there is a lability here, probably you're dealing with PPHN, which is very, very common condition. And if there is sudden pallor, you're probably dealing with shock or IVH. Okay. So you think of these conditions and the way baby behaves when you ventilate the baby, the hand begging, you can get lots of informations. Okay. And appropriate action depends on that. Last but not the least, if a baby is agitated, probably you think of analgesia and sedation. Sometimes we forget this. Worst case, if you're not able to ventilate properly, you have checked everything, circulate ventilator, everything is fine. Last option, you can try muscle relaxation. You should not try to knock out each and every neonate. It's the last option. Okay. I hope that is more than enough. Thank you all. And I'm okay to take questions. Just I'll go through the chat box once. If there are any questions at all.
Yeah, 2 questions are there.
Can value of TI affect PV loop slope? See, ultimately TI will decide the inspiration, how it goes. Suppose the TI is very low, the inspiratory loop might not go up properly. It might end up very abruptly. Probably inadequate TI will not give a proper PV loop slope. The best loop or graphic for that is flow time and the